Hospice at Home. I'm a regional palliative care nurse for region. I would like us to use our chat box to introduce ourselves. If you have logged in one laptop, so you can introduce everyone you are with using the chat box. Today's session topic is about ethics in palliative care. So this topic will help us in managing our patients in palliative care, basically, and mainly in decision making. So it is very important to take a look at this topic and be able to assist our patients when it comes to ethics. So in the meantime, due to we are behind in time, I would like to introduce Bonile Simelane, who is going to present for us today in today's session about ethics in palliative care. Then can I ask Bonile to come forth and present our topic for today. Thank you.
Good day, everyone. My name is Bonile Simelane, as the facilitator has just said, a nurse here at ECHO-Eswatini Hospice at Home. Today's topic is ethics and moral reasoning. Our objectives here is to understand and apply principle-based ethical frameworks in palliative care. We'd like you to understand the steps in ethical decision-making, and again to understand the steps in ethical problem solving. I think that one is clear. My introduction goes like this. Ethics are just principles that guide us as health workers and the doctors in the way we do any decision making. They are just not laws, but they are just guiding principles. They apply to all medical care. Two, the moral reasoning involves acknowledging and addressing issues of morality. I think that one is clear. Moral uncertainty, whereby you find that you are not sure whether you're doing the good or the right at the same time. And moral dilemmas, whereby this one is a really conflict, whereby you have to do a moral duty. And this can lead to moral distress, which is a very, very devastating situation, whereby the nurse can even go to disillusions. And at the end of the day, you find that the nurse throws up the towel. What are the ethical frameworks in palliative care? Let's just look at them. Number one is autonomy, whereby we respect the patient's self-determination. Here we have to make sure that they are informed consent. The patient's rights to treatment decision is observed. Complete treatment and diagnosis information, which is should be disclosed. We shouldn't lock out the patients. We shouldn't lock out any information. It's for the good of us as health workers and for the good of our clients as we take care of them at the end of life, whereby we want to improve the quality of life in the time remaining. Number two, we have to look at the beneficence and the non-maleficence, whereby we promote patient well-being. The patient here is the patient centered care is important here. Number two, we need to be honest. If I would say we should give our all out there. We should balance the benefit, risk, and the cost. I think that one is understood because variety of things need to be looked at as we do the processes, and at the end we have to benefit the patient too. That's one benefit that we should not take care of. We should respect their decision and protect them from harm. And I think there we should define that. I don't need to elaborate, but we do no harm, which is not going to benefit the client. Let's look at point number 3, where we should look at the justice as an ethical framework in palliative care. There should be fair distribution of resources for all. We should equally access. There should be equally access to health care. We shouldn't charge. We shouldn't discriminate. We shouldn't give what is supposed to be higher than the other one. That is sharing the care, because it's one goal we are looking at to benefit and to benefit the patient and to have a improved quality of life. The ability, okay, we should abide by the country's laws. Here we should be very, very careful that even the person would think that he would one day or anytime seek justice. We should be able to abide with the country's laws in a way that the patient at the end of the day doesn't sue us. Let's look at the data-based ethics in our frameworks in palliative care. Here it's a concern of us. It's us here, whereby we should be compassionate. We should be trustworthy. The patient should trust us in all aspects of what we are going to deliver and what we are going to help them at the end of the day. We should practice discernment and conscientiousness. That is, the conscious in me should always be noted. And okay, let's go ahead and see how we can practice this ethical decision making in palliative care. The first one is to evaluate and communicate. Here we need to consider the stage of the illness, the patient preference, and the family's wishes. The patient as an individual and relevant care plan. Number 2, we need to consider the ethical principles. We should identify the ethical dilemmas. Number 3, we have to make the decision. Identify the key decisions here. Evaluate the patient's decision-making capacity. We shouldn't lock them out. We should evaluate the patient's decision-making capacity. Engage in discussion with the patient's family and care team. We should employ assumptions and present factual information. We shouldn't steal them of the factual information. Number 4, we have to share the decision making. That is, we avoid making decisions in isolation. So you see here, it still says we shouldn't put them at our back, but they should be with us as we journey them through. We avoid making decisions in isolation. Number 5, we should implement the decision and change if necessary. Implement the decision and change if necessary. Number 6, we should respond to objections and challenges within the health care team and family. We should respond to the objections and challenges. And then here we have the steps now to solve the problems. Let's see how we can solve this one. This one, to me, I would love you to take this one into, if it were me, I would say take it to your pocket. Make a little pocket diary whereby you can revisit every time you need to do the steps in ethical problem solving. Now let's check the box. Let's check and see what is in there. We have to define the problem first. Differentiate clinical problems from ethical problems and ensure that everyone identifies the same issue. Everyone, even the team has to identify the same issue here. Okay, let's start the wheel. Let's try and start the wheel. Clarify the facts and assumptions, whereby we differentiate known facts from assumptions about the situation and ensure that all parties have access to the same frame, to the same facts. And then we have to just develop a list of all the options. Just open up your envelope. Just list all the options. Avoid collapsing options into yes, no, absolute. Whereby here we have to maybe give more instead of maybe saying we need to discontinue treatment. What else we have to do? It's not a yes, it's not a no. If it's a no, what else can we add up on the patient's treatment? Just don't leave any order, any intervention hanging. We should assure that all possible actions are evaluated. I think the one is clear. Let's check the drama again and evaluate all the options we've done above. We should consider the relevant laws, policies, and ethical principles. You know that in every country, in everywhere, there are laws and politics, ethical principles we should consider. We should address the rights, the duties, and interests of all involved. Remember, it's the patient here, it's the family here, it's the health team. And then at the end, we should choose the option and implement. Here we should consider re-evaluation. We should assess and follow up. And if this step fails, don't be shy, don't be afraid to go back and start afresh in defining the problem. You clarify, you develop a list of options, evaluate again all the options, and choose the options and implement. Okay? In closing, I would love to say compassion, in which all ethics must take root, can only attain its full breadth and depth if it embraces all living creatures and does not limit itself to mankind. I thank you.
It's a wonderful presentation about ethical dilemmas and ethics. The bottom line here, I note that whatever we do, either it's an ethical problem or it's a clinical problem, it must be of benefits to the client. And another thing, we must be trustworthy to the clients in order for us to make decisions that will benefit to the clients, so that since the clients can trust us. So in the meantime, I would like to invite anyone who needs any clarification or who has a question about our presentation that we have just heard from Sibonile. You can use the chat box, even then is allowed, or you can raise your hand. In the absence of question or in any additional clarification, I would like us to move on. I would like us to move on our program of today's program. Since there is, even the chat box is quiet and no one is raising any hand, we'll move on to the next item, which is our today's case presentation. It will be presented by Shatikulu Palliative team. I would like them to come forward. Shatikulu, are you ready to present? Shatikulu team, are you ready to present the case for today? Nompumelelo, do you hear me? Nompumelelo. Nompumelelo, are you there?
Hello.
Yes, thank you. Are you ready to present, Susie?
Yes, we are ready.
Okay, I'm giving you the floor now.
Hi, everyone. My name is Nompumelelo Tashwago, palliative care nurse at Tatikulu Government Hospital. I'm today's presenter, presenting on behalf of Tatikulu Palliative Care Team. I'm with Pindile Nkambule and Nontobeko Ngwenya. Okay. Our patient is a 35-year-old female diagnosed with the chronic lung fibrosis. She is oxygen dependent. Our problem of concern, please go back a little bit, go down. Yes, it's okay now. Our problem of concern is our patient was diagnosed with lung fibrosis. She is oxygen dependent. Her caregiver, who is the mother in this case, wants to win the patient from oxygen and take her home to try traditional medicine, yet the patient wants to stay and continue with oxygen therapy. Secondly, our patient is also anemic with an HB of 5.7 grams per deciliter. And her mother is refusing blood transfusion based on religious belief. She came presenting with history of cough, shortness of breath, loss of appetite, loss of weight, dizziness, and headache since a week ago. No surgical history was reported. Patient is known with HIV. She is on ART since 10 January 2016. She was also treated for PTB on 2020 November, where she finished her course and she was restarted on 9 11 2021. No history of other chronic illness was reported by the patient. Past medication, she was on ATTs, PTB treatment. Currently, she is on ART, whereby she is taking TDF, 3TC, and DTG. She continues with the PTB treatment because she was restarted. She is also getting IV antibiotic, which is ceftriaxone BD for 5 days, CTX, the high dose of 1920 milligrams TDS for 7 days. She is also taking prednisolone, 40 milligrams OD, which was prescribed for 7 days. Then it was titrated down to 20 milligrams OD for 7 days. She is also getting ferrous 200 milligrams BD for a month. Okay. Our patient is currently unemployed. She was working as a domestic worker. She stopped education at primary level. Socioeconomic class is low. She is single and she reported no lifestyle habits were reported. Her mother is hypertensive on antihypertensive meds. The issue of advanced directives, we are working on it as a facility, so we're gonna skip it for now. Review of systems. Her vital signs were temperature was 36 degrees Celsius, BP 75/50, pulse was 118 beats per minute, respirations were 38, which is high. Oxygen saturation was at 77%, which is low. Pain score, she scored 0/10, which means there was no pain. ECHO, she is at 4/5. Our patient is bedridden. Other symptoms, pain, I said she reported no pain. Dyspnea, she had severe dyspnea, anxiety, She is worried due to the illness. Agitation was severe, depression severe, drowsiness or fatigue severe, nausea and vomiting. None. She reported no nausea or vomiting. Anorexia is mild. Constipation, she reported no constipation. Dry mouth, no. Poor mobility, it's a 3, which is severe. Okay, we did lab investigations whereby we did ECBC. Results came back with an HB of 5.7 grams per deciliter. Normal range is between 3.5 and 16.5. Our patient has the anemia in this case. TB lab was also done, which came back with positive results. Gene expect was also done to confirm. Surprisingly, it came back negative. She has a CD4 count of 525 and a viral load of 565. Other investigations which were done were chest X-ray, which revealed severe lung fibrosis with bullae. Continue. Please scroll down. As a palliative care team, we had our plan whereby we communicated the diagnosis with the patient and the family. Psychological support was provided by a psychologist. Spiritual support was also provided by our facility pastor. Management, the anemia was also managed whereby the patient was transfused 2 units of packed cells and was also given a hematite. Oxygen therapy was continued to improve breathing pattern as well as the oxygen saturation. Ongoing counseling provided to both patient and mother on importance of adherence to treatment and dangers of imposing her beliefs on the patient. That's all we have as Statikhulu Palliative Care Team.
Thank you very much, Melela. What a wonderful presentation we have here. Yeah, I can see in the concern for patients, it's a very much big concern even for me sitting here. I get you saying the mother wants to win the patient from O2 and he does not want the patient to continue with gas transfusion if the patient has an HB of 5.7. Yeah, that's a problem. I would like to give the floor to our spokes to ask questions or give any clarity or add on how we can best improve the management of our patient here. And anyone who has any suggestion or comment, you can use either the chat box or you can raise your hand. Thank you. Okay, anyone who wants to ask any question or add in order to improve the care of our patients? Anyone? Anyone? Team? Let's help the team here. We want to solve this. I can say an ethical dilemma here. The mother believes in religious, has a religious belief, and he wants to win the patient from O2, where the patient is dependent on O2, and the patient has an HB of 5.7, which is way lower than the normal range. I think it's like so I think there's a very much important decision-making steps that we have to take place here in order to improve the care of our client. Anyone can have any suggestions or any comments or any thoughts? Oh, I have Mr. Mashlam next to me raising his hand here. Let me give the floor to Mr. Mashlam.
Thank you so much, Mr. Mabuza, and thank you so much, Tactical team, for wonderful case presentation. And thank you so much to our senior nurse, Bomile, for a wonderful presentation. My question is for you, Tactical team. I want to get some clarity. Has the spirituality of the patient and family been assessed?
Mr. Masham has a question for your team. Did you get Mr. Masham's question?
You muted us, though.
Oh, sorry.
Yeah.
Did you get
unmute us?
Okay. It's okay.
Yeah, we got the question.
Okay, then you can go ahead.
Yes, the spirituality of the patient was actually assessed. The patient is a Christian, so her beliefs are totally different from her mother's beliefs. That's why she opted that we can involve our institutional pastor who comes every day, because that one comes to preach almost every day. That's why she preferred that we can use that one as a spiritual support for her.
Oh, thank you. I think I can get that. I'm asking that because I'm seeing some clash of beliefs here, yet they play a major role in how they cope. I think Tatikul has considered that the mother also is a patient who's going under suffering like the client is. So we may not ignore what the patient is saying and ignore what the mother is going through. I believe you have provided thorough and in-depth spiritual counseling for the mother, and I'm scared looking at what the patient is going through. If she might die without verbalizing what she wants, the facility might be sued. So I don't know how you are handling that dilemma, because then now there's the family spirituality and the patient spirituality. I was in the mood to ask if you have get an opportunity to sit down with the mother, get to know the patient wishes and wants, and explain them to the patient who says she wants to make that decision. And in such a dilemma, the processes that were shared during the presentation in ethical decision, the very special and very important one that you need to make the decision. In fact, to communicate before you make the decision. So the communication has to consider the state and who is making the decision. I don't know at this stage if we have not done advanced care directives. I'm worried if the patient is still in a position to make his or her own decision very well. So then you can identify the process decision maker in this case.
in our case, the patient is still able to make her own decisions.
Oh, thank you so much. I think that's better. I think it's the issue of allowing the patient to share her wishes with the family. If you can facilitate that, it can help the family to know what to do to help the patient for the best, and even not clash with you to feel like you are sidelining them because this is their patient after all. If it calls for a family meeting, you need to prepare for that. I don't know whether we have already engaged the end of life advanced care plan for the patient, because that one will help you to know, because the mother is a reason why he's feeling like we need to then go to religious people, and we need to ascertain and find out why the mother is feeling like we need to take the patient to religious. Maybe it's the issue of the goal of care and advanced care planning. It was not discussed with the family and it was not agreed with the healthcare team. So maybe you imposed the plan of care without involving them in it, so that they can know their role and how to support the patient. So that one is very important to deal with these ethical issues. Once you sideline the patient during the admission, when we are planning on what we are going to do and why we are going to do it, and then the patient and the family must agree, so that they know you haven't killed their relative, but you have been doing your best to support. And they will tell you why they think the ritual areas will work and why the patient feels it's better when it's there. So including the family members will help you to know, especially with the issues of who's going to make the decision for the patient. I'm scared. If this patient can be silent today, not be able to speak, if we don't know who is making a decision, the mother will then eventually take advantage and say she is the decision maker for the patient who is now unable to speak. So I will encourage Atiku to take a quick move towards establishing the advanced care directives. If the facility doesn't have them, then this must be said in the management, because we are running a risk of imposing the care to our patient that they don't want. And at the end, they will say, we are a poor performing facility, yet we're thinking we're doing our best, but the best out of the quality of life defined by the patient. So may I encourage you to go back, sit down with the family, discuss the issues of end of life care, discuss the prognosis very well with the family. There are many issues that are behind of what the mother is deciding. What is really the family saying? Remember, palliative care is about the patient and the family. So both must agree on what is going to happen today. Yet the center of everyone, it's our patient who is deciding what needs to be done.
Thank you, Mr. Matango.
Thank you, Nkumelelo and team. I would like to continue, give room to anyone else who wants to make an addition or who has a question in terms of our presentation, be it a case or our presentation earlier on. You can use the chat box. It's okay. You read the question from the chat box. Or you can raise your hand. Can you unmute yourselves? Can you mute yourselves instead? Sorry. Unless we want to talk. Hello.
Hello.
Can you mute yourself unless you want to say something?
It's muted.
Okay. Okay. Team, anyone? I'm giving you 30 seconds. Okay, thank you, team. Thank you very much. Our next item, is a recommendation from our today's expert. I'm not sure if he still has something to say or he exhausted everything on the comment earlier on. Our next item will come from Mr. Mahlangu, who is our expert for today's session. Mr. Mahlangu, is there anything you want to continue at, or you exhausted everything earlier on?
Thank you so much, Mr. Mabuza. I can add a few things and put some emphasis on things we can take into our facilities today. May I just emphasize a few things that we have been discussed today. Thank you so much, team, for being with us. And I'm happy that our clients, I think particularly you are benefiting something from today's session concerning the management of your patient. Is that correct?
Correct, Mr. Mahlangu.
Yes, so I think our take-home today will be concerning the particular case is to attend to the spirituality of the patient and reinforce it. Sometimes, I guess the prognosis of the condition, the doctor is already ascertained it. If now the prognosis is agreed upon to be now non-reversible, I think start the issues of end of life now as possible as you can, in a way that will build the family so they can prepare. Because now that is living on oxygen, I think the pros and cons of oxygen have been shared with the patient and is aware that how far the oxygen can go, so that they can prepare, you know, so that they can know what to say. If they are family members that have children, they can be allowed to come and see the patient. So sit down and see what the patient wants really in life, what makes, gives the patient hope to continue going forward. So the patient wishes, if shared very well between the family members and the team at its best, it will help. And then it will also benefit you to even get the proxy decision maker who is going to make the decision. And all these things must be documented in the patient file so that every care team that is involved in the care of the patient can know what is happening and how is going to survive. If possible, these patient relatives must be linked with the home-based units that we have in the country and the two ones we have in the region. So for continuity of care, especially the care of the relatives. So I will advise, let us go deeper into holistic assessment and continue assess the family to see if how ready they are for any news that may come, so we may both prepare them. So I will encourage you, don't wait for the patient to be completely discharged. So before you discharge the patient, please do find out what is happening at home, who lives with the patient, how best you can be supported. So I think the hospice at home base can be a success. And please consider monitoring the situation of depression. You know, the patient on oxygen may commit suicide. So don't take it lightly. Find out those issues that are stressing the patient so that you can manage it very well. I'm happy that there's a pastor there. There is a psychologist who attended the patient, which is that very good. So, but then we have to monitor if the depression is going down or it's continuing to give a problem. So I think that one will help us to know how best we can support the patient. Then my last input will be the emphasis on what Nabe Bongile presented today in terms of the ethical decision making. That you need to consider to identify the decision maker, evaluate the decision-making capacity of the patient now and then, because once you have oxygen, anytime the decision-making might be altered. So engage with the patient and the family and the care team in the decision making, and explore all assumptions and present factual information concerning the patient, and don't rush to decisions. Ensure that as a health worker, you don't make the decision in isolation. And also to the ethical problem that we are facing today of the mother wanting to take away the autonomy of the patient. I will say that always sit down, find out, you might find out that it might not be an ethical issue, but a clinical issue. The mother might feel that you are failing the patient, but look at differentiating the problem and then clarify everything and ensure you are on the same page with the patient, the family, and the whole team. And always consider assessment and in-depth assessment and team approach will support us. I think the patient will say thank you to you, if not this way. If God takes it finally, the God in heaven will bless you as a team. That will be my advice and my input in this care. Thank you so much. In closing the session, I will say we are so happy to have you today. In our chat box, we have shared a feedback link. May we request you, colleagues and participants, to click that link in our chat box, and then it will lead you to our feedback form, and kindly take that 30 seconds and fill it. It helps us to improve and do better in our sessions. So may we kindly request you all to click the feedback link there, shared in our chat box, so that we may all have your input towards the sessions we are having here at Hospice virtual platform. And then again, we are going to have our session on the 23rd of February. It will be on the 23rd of February. We will be looking at ethical dilemma on decision making and disclosure in terms of communication and disclosure of the proxy decision maker. So we'll be looking at the ethical dilemmas. Today we're looking at the ethics. So in our next session, we'll look at the ethical dilemma of how do I disclose and how do I communicate the better news to the patient, and how do I deal with the issue of proxy decision making to ascertain in this situation, for example, who is the decision maker? How do I as a health worker facilitate the dilemmas when they are there in terms of who is to make the decision? So please bear with me. I've spent around the text break. It was supposed to say 23 February 2022. We'll be having a case on that. And we wish all the best. We will be there while we are going through that session. And we invite you to continue joining the session. If you want to be part of the session, we encourage you to contact Sandile on the email at sandile@eswatini.com, or you can WhatsApp to 7929-7140, or you can share the registration link with you, and all the information of this didactic session and the case presentation and the Zoom video that we have today will be shared with you via your emails. Thank you so much. May I hand over to Mr. Mabuza before we close?
Thank you so much, Mr. Mashal. Thank you so much. I'm sorry, colleagues, we have some maintenance going on in our facility, so we will hear some welding noises outside here. Sorry for that. In closing, all today, the program has announced and talked about our feedback. So we had a very wonderful presentation here. For me, I think it's very clear for our team on how they are going to continue the care for our patients. And I think they've noted everything that has been brought forward to them. They will take it and go and implement. Thank you so much, team. Have a blessed rest of the day. Bye.
Bye.
Bye, everyone. Thank you.
Thank you.
Oh.